everyone, and welcome to Stop HIV and LGBTQ Seniors. I'm your moderator, Rachel Deere with DKB Med. Thank you for joining us. You'll notice a console in the bottom of your screen. There are a number of frames, and we encourage you to move the windows to your liking and minimize what you don't need. You're also able to submit questions for the faculty by clicking the Q&A button towards the bottom of your console. Questions will be addressed during our Q&A session at the end of the presentation. At the conclusion, you'll be able to access the evaluation and a test for credit by clicking the Claim Credit button. Your thoughts and comments are important and will help us develop CME activities on this and similar topics in the future. We're pleased to welcome two expert faculty members, Dr. Miley Karras from the University of California, San Diego, who's been caring for people with HIV since 2004. And she has a special interest in successful aging of people with HIV. And Jeff Taylor, Executive Director of the HIV and Aging Research Project in Palm Springs, California. Thank you both for joining us.
Thank you. It's wonderful to be here.
Yeah, thank you, Rachel, for putting this together. We appreciate it.
Okay, here are learning objectives for the program. Identify patients who should be screened for HIV. Assess your patients for eligibility for PrEP. Assess factors associated with the aging population, such as social stigma and polypharmacy, that may complicate HIV treatment or warrant special considerations. And evaluate data concerning safety and efficacy of medications with lower risk of side effects or drug interactions or with simpler dosing and administration requirements. We have a few knowledge questions throughout the program. If you don't see them, you may need to scroll down as it's sometimes cut off on smaller screens. So let's start with our first pretest question. In general, the risks for HIV in older adults are different than for younger people. 1 true, 2 false, or 3 do not know. Please answer. Thank you. And we will revisit that question at the end of the first presentation. So before I introduce Jeff again, I'd just like to play our first video. This first video features real people who will tell bits of their own personal stories about their lives as older people in the LGBTQ community.
My family completely hates the fact that I'm gay. They say that I'm going to burn in hell.
I was in my last semester of the School of Law back in Mexico. And I used to have a lot of bullying about hey, what's up with you got AIDS, and it was like a joke, but it was something very terrifying just to hear about people talking about it and the way they were expressing themselves about it. It was very bad.
I do find there is a lot of stigma about me being a senior long-term survivor, or being my age. I'm 62. And amazingly enough, within the community itself, the gay community, the younger gay men tend to dismiss us older men.
Being an older guy, I think that a lot of people, I have a lot of people, even on the dating sites and stuff, that are just going, old man, why don't you just close this thing out and save your money?
Like, you're already over the age of 50, or for that matter, 45. So you're no longer physically acceptable, physically attractive.
One of the issues that many of us are dealing with is isolation. It's being alone. It's one of the biggest fears.
I really had withdrawn from friendships and from being active out in society.
Nobody in my family wants to talk to anybody. Nobody wants to video chat even. Nobody wants to get to know anybody. No one wants to take the time to do any of that stuff right now. Everybody seems to be stressing out. And so it's stressing me out. And so I just turn things off, and then I become more and more lonely and sit here watching TV and just taking care of myself.
I know the negative effects of being isolated, and I really have made efforts to fight against that, to reach out.
Isolation, it rips you apart. It depresses you. It really takes away your sense of belonging, and it is very real. for many of us who are aging.
And so what helps keep me from being isolated is to reach out to those folks that I know who are in their homes, who are sheltering, and aren't necessarily reaching out to others in their community.
Doctors. That's the only ones that I can clearly talk to about anything right now, because everybody else just kind of bashes me for doing whatever I'm doing, for being gay.
I am part of an aging population where we are the first wave. We are going to be the first wave of seniors who are diagnosed living with a virus in our bodies.
And now I'm going to turn things over to Jeff.
Great. Thank you, Rachel. So first, we should review what the current CDC guidelines are for HIV testing. Most of you probably know this, but it's good to have a quick review. So they state that all people aged 13 to 64 years old should be screened for HIV at least once, unless the prevalence of undiagnosed HIV is less than 1%. And I think, I take exception to this because, as all providers know, and certainly people living with HIV know, that sex doesn't magically stop at 60, 64. And at 65 and older, it doesn't happen. So we'll get into this later, but we need to bear in mind that screening should be happening whenever it's appropriate, not just up to age 64. And also for all people starting treatment for tuberculosis, anyone seeking treatment for sexually transmitted infections, obviously, and people at higher risk for HIV should be screened at least annually, if not more often, if they are sexually active. And also all people with signs and symptoms consistent with HIV or an opportunistic infection should, of course, be tested. So who is at risk? So the same risk factors for younger people also apply to older adults. So some of these age-related factors may place some older folks at increased risks. Obviously, birth control is not a concern, so people aren't as likely to use condoms. And especially for older women, postmenopause, decreased lubrication and thinning of the vaginal wall is an issue as well that makes them more susceptible to HIV infection. And people may not perceive themselves at risk or may be embarrassed or afraid of getting tested for HIV. And that's not just people at risk for HIV, but also their providers when it comes to being embarrassed and not wanting to initiate that conversation. We'll talk more about that later, but it goes both ways, and we need to be aware of that. And then, of course, we need to be aware of the local HIV epidemiology. How great is the risk in that community? And does that mean you need to test more often and take other measures? So this is a bar graph just showing the new HIV diagnoses in the U.S. by age in 2018. And you can see it peaks ages 25 to 29, which makes sense. That's when people tend to be most sexually active, and decreases in a stepwise fashion through middle age. But as you notice, significant numbers of people are still having sex in the ages of 55 to 59, certainly over 50. And even in their 60s and beyond, it doesn't change that much. So people are still having sex, and we need to be aware of that as we think about prevention for older people. And these are a couple of graphs showing the new HIV diagnoses among people over 55 in the U.S. by transmission category for both men and women. And so as we see for the men, gay sex is obviously the largest contributor. The next would be heterosexual sex. And we need to remember that it's not just a gay disease, and that heterosexual folks are just as much at risk. And IV drug use is still a concern. And we need to bear in mind that MSM can also be having sex and injecting drugs at the same time. The meth epidemic is a huge issue in many places. And for women, heterosexual contact is overwhelmingly the way people are infected, distantly followed by injection drug use. So as a provider, what should you do with people who are over 65? So first, you need to ask yourself who is at risk. So in a population of people over 50, 65% of men and 45% of women reported having sex in the last year. So they're at risk. And 20 to 30% of older men and women remain sexually active well into their 80s. So again, this puts them at risk, and we need to treat them as such. And 9% of men and 3% of women reported having same-sex partners. This is in the general population. And 20% of men and 24% of women reported condom use the last time they had sex. And 65% and about 69% of women had not received a test for an STI. So this is of concern because people are having sex, as we see, but they're not getting tested. And over 5% reported that their sexual partner had an STI at the time of sex. So obviously they're at risk, and we need to be more proactive in treating them. And 23.5% of men and 13% of women reported alcohol intake prior to sex. Obviously, alcohol and other drugs. Cannabis use is increasing as it becomes legalized. And this age population, we're using cannabis and other drugs back in the 60s, 70s, and 80s. So that's not going to change as they get older. So the bottom line is that older people are having sex. So we need to be comfortable and deliberate about asking them. So we're going to return to our post-test question that asked, in general, what are the risk factors for HIV in older adults? And are they different for younger people? So that was the question, and the answer, the risk factors are the same in younger and older folks. So yeah, the take-home message is that it's the same risk factors that apply in either population, and we need to bear that in mind.
I'm very clear when I meet someone, a new doctor, and I said, this is my story, and I know how to be responsible about my health.
I was getting more sexually active, and then I was getting tested for HIV and all the different things that you can have and stuff. So I went to the Human Resource Services, and they got me on the PrEP.
My healthcare provider was the one who actually brought it up about my sexual activity, and it is a comfortable conversation that I routinely have with him.
I think fear is like the biggest thing that we're plagued with pretty much, because it's either coming out or the lack of knowledge of knowing what we have or what we can have or what it does to us. I think that more education needs to be done because of like what PrEP does.
I had to do my own research, and again, that came up in my discussion with my healthcare provider, my family history, my health history. So it was a very much informed decision for me. And I am happy that I made that decision. It's just another layer of protection for myself.
I didn't know what it was, and I just said, okay, you know what? If that's what you think I need, I'm going to go ahead and do this. And so far, so good.
I do ask my partners if they are on PrEP, as well as I let them know that I am and how long I've been.
Well, my primary care doctor thought that I was HIV positive when he saw that I was taking PrEP. And I go, don't you know that it's an anti-HIV drug? And I said, I'm taking it for precaution. And that was the end of the conversation. He never ever mentioned anything sexually or anything else about it. He just moved on.
A good healthcare provider is not in the business of judging. They're in the business of listening and doing what's best for the patient. And the best thing that a healthcare provider can do is give the patient the information that they need so they can make the informed decision on how to utilize it.
Many doctors don't ask questions. They just wait for you to share something. And it is important for doctors to understand the patient as a whole.
But I'm going to have a sit-down conversation with them and say, look, this is my situation. I'm gay. I'm on this. I'm taking these things. I don't feel as though that you're taking care of me properly. Either give me another doctor or else start learning more about me.
That was a great video. I really love hearing those stories, although as a provider, sometimes I'm a little embarrassed. It reminds me to continue to keep talking to my patients about these issues. So that's going to segue us nicely into talking about PrEP, or pre-exposure prophylaxis. So we're going to start with the pre-test question. Which of the following is a contraindication to PrEP? Is it HIV infection, mild kidney disease, continued injection drug use, all of the above, or don't know? And we'll get back to this question at the end of the segment as well. I'll give folks a couple more seconds. So pre-exposure prophylaxis, or PrEP, is for people who do not have HIV, but who are at risk for HIV, either through sex or injection drug use. And PrEP has demonstrated safety and efficacy in sexually active men who have sex with men, heterosexual men and women, and transgender persons, as well as people who inject drugs. If you're seeing someone for post-exposure prophylaxis, that's a great opportunity to introduce the idea of potentially taking pre-exposure prophylaxis once they're completed with their post-exposure prophylaxis regimen. I think it's also important to note that if you have a serodiscordant couple where one person is HIV negative and the other person is HIV positive and they're heterosexual and trying to get pregnant, maybe another way or another reason to consider keeping them safe, keeping the serodiscordant or seronegative partner safe. There are some populations in which we have less data about PrEP, most notably adolescents. So it's a little bit more difficult when we're talking about PrEP for folks younger than 18, but thankfully we don't have to do that today because we are focused on older adults. CDC offers some practical guidance and cues that should really be prompting a PrEP discussion. For example, recent sexually transmitted infections like syphilis, gonorrhea, and chlamydia, history of inconsistent condom use, HIV negative partners of people living with HIV, specifically if the viral suppression status is either unknown or not optimized, and also persons who inject drugs, and particularly if they're sharing equipment. Now, we know from our US opioid surveillance data that persons that use both opioids and methamphetamines are particularly at risk for HIV. And for those of you who consult in the hospital, particularly the infectious disease physicians that are out there, I find this to often be a really ideal time to introduce injection drug users who may be there for another reason, like an infection, to PrEP, because we have the time. And sometimes they're often getting sober if they have to be in the hospital for a while. It's great to offer that along with, medication assistance therapy if that's feasible and they're interested in that as well. But of course, prior to PrEP initiation, one first really needs to ensure that the person is HIV negative and that they do not have any symptoms of acute retrovirus syndrome where one may actually be experiencing a false negative test because it could be too early to detect either the antigen or the antibody in our most commonly used tests. You also want to confirm that the patient has normal renal function, as well as determine what their hepatitis B infection and vaccination status is. So for those of you who have not yet prescribed PrEP or who often struggle with talking and counseling about sex, particularly with older adults, these are the questions that you may want to start with. And I know we have a broad audience, so forgive me if you're all familiar, and this is all old hat to you. But if there's anyone out there that still struggles with this, sometimes it's nice to preface these questions with something like, I'm going to ask you some questions. It might seem a little bit personal, but really I want to provide you with the best education I can about your health. If you don't want to talk about it, we don't have to, but here are the questions that I want to ask you. So do you have sex with men, women, or both? What kind of sex do you have? Vaginal, anal, oral? As clinicians, we sometimes use terms like anal insertive and anal receptive. If you're saying those terms and the person that you're talking to looks confused, like you're speaking to them in another language, then maybe consider using some of the lingo, like, are you a top? And that's anal insertive. Are you a bottom? Or do you do both, which is versatile? It's also important to, when you're asking these questions, to probe for a little bit more detail. So maybe follow up a question like, do you know the HIV status of your partner with something like, how do you know? Do you trust your partners to self-report their status? Are you asking them to see the results and the date of their last HIV test? There are all sorts of different practices out there. And as you're asking these questions, you are also empowering your patient to think a little bit more about, okay, how well am I really protecting myself? And am I actually at risk for HIV? Because I'm not doing a super great job at talking to my partners about their status. And I'd also follow up some questions like, do you use alcohol or drugs with, sometimes people forget to use condoms when they use too much alcohol or they use other types of drugs. Does that ever happen to you? And it can really get people thinking about, what are the situations in which they may not be making a decision that they normally would be making around their sex life. And in reality, these follow-up questions really do help you as a provider to get a better idea of their HIV risk, but it also, again, helps them. You're counseling. and educating them as you're asking these types of questions. So other things to talk about include potential side effects. You really want to do expectation management if you're starting somebody on PrEP in general. Tenofovir disoproxil and FTC, as well as tenofovir alafenamide and FTC, are really well tolerated, but they can cause some GI upset, nausea, diarrhea, some stomach pain, particularly as the body is adjusting to medicine. And if you communicate that, then that may increase chances that the person will continue it and just kind of hold on until those symptoms abate. It's also associated with mild kidney dysfunction, as well as some rare situations, some decreased bone density. And you can reassure people, like, hey, we're going to regularly be monitoring your kidneys. And, the kidney dysfunction that we see with this medication is often reversible. The reason that we're closely monitoring you is we're going to stop it if we see any evidence that it's starting to cause you any harm. Of course, we want to talk about adherence, particularly as it relates to HIV resistance. And you can talk about how, people who take their PrEP every day really had remarkable efficacy. Like, they did not get HIV from their HIV seropositive partners. And that's, again, in heterosexual men, heterosexual partners, transgender persons, as well as IV drug users. So it is remarkable. But if you don't take your PrEP well and you're not as adherent, there is always a little bit of risk of, if you do acquire HIV, you could develop some resistance to those drugs. So talking to them about, like, if you have to stop or you run out, call me, call the clinic, let's talk about either getting you a supply so that you can be covered from, like, your last sex event, or coming up with a plan so that resistance does not happen to you. As far as time to protection, in truth, the time from initiation of PrEP to maximal protection really is unknown. We kind of extrapolate some data from studies in persons who are on PrEP, where we collected their blood, rectal, and vaginal tissues. So this is kind of an extrapolated process. But really, the maximum intracellular concentrations of tenofovir are reached in blood and cervical vaginal tissues around 20 days of taking the medication. In rectal tissue, it's much faster, so it's closer to about 7 days. And I clarify that PrEP only prevents HIV. It doesn't prevent any other sexually transmitted infections, and it does not prevent pregnancy. It may sound silly for you to say that, but not everybody understands that. So just make sure that you comment on that. So really, this can be a great opportunity. So baseline testing, there's, I think lots of things that obviously you would want to do. You want to make sure they are HIV tested and they do not have HIV before you start them on PrEP. Great opportunity to do sexually transmitted infection testing, gonorrhea, chlamydia, syphilis, hepatitis C. You'd like to do a pregnancy test. It's not necessarily contraindicated in pregnancy, but that might be something you want to know, before starting PrEP, because then you can more appropriately counsel them about risk to the mother and potentially the fetus. Measure the creatinine clearance. I said earlier that tenofovir disoproxil needs to have normal creatinine clearance by glomerular filtration rate prior to initiation. The new formulation of PrEP, tenofovir alafenamide, can be used in people that have some impaired renal function down to 30 mils per min. And the big thing that you absolutely need to do is screen for hepatitis B. So many of you already know that hepatitis B is adequately treated with a combination of FTC and tenofovir, either disoproxil or alafenamide. And if someone is also chronically infected with hepatitis B and they're starting PrEP, and then they decide to stop it all of a sudden, if they have pre-existing advanced liver disease in that context, you could potentially, or they could potentially put themselves into a hepatitis B flare. So that's particularly important to know. And it's also a great opportunity to vaccinate them for hepatitis B and hepatitis A if they have not yet been immunized. So the medications that we use for PrEP currently, there are only 2, although I suspect that we have at least one more coming. I don't know the timeline for that, but they are tenofovir disoproxil emtricitabine and tenofovir alafenamide and tricidabine. These are formulations of the same drug, but they're slightly different from each other. So the classic tenofovir disoproxil, or Truvada, that was approved in 2012, and it was approved for men and women. Again, you need to have normal renal function when you're starting it, and it's currently available generic. So it may be easier to get for people because of that reason. Tenofovir was more recently approved for PrEP in 2019. It is only approved, however, for men and transgender women, but not cisgender women. It's primarily because, unfortunately, they didn't recruit enough women in those studies to actually have a strong endpoint for them. So women cannot use the new tenofovir. That being said, it can be used in people that have some renal dysfunction, and it also has less bone and kidney toxicities. However, tenofovir alafenamide emtricitabine compared to tenofovir disoproxil has recently been associated with greater weight gain taking the medication, and probably a little bit more of some negative lipid changes. Although when they've looked at the differences in the lipid changes, they don't seem to have any clinical significance. So PrEP does require fairly close monitoring as well as ongoing education and counseling. You really want to assess for side effects and adherence, just like with HIV. Every 3 months, if you are treating women, you should be getting a pregnancy test for women that may be at risk for that. Sexually transmitted infection testing should be done also every 3 months in persons who have symptoms or persons who may be particularly at high risk for recurrent sexually transmitted infections. If they've had a lot in the past, you may want to check them every 3 months rather than every 6 months, just to be able to catch something sooner than later. And every 6 months, we evaluate the creatinine clearance and any other potential new diagnoses that might impair kidney function, for example, like high blood pressure or diabetes, and also do STI screening regardless of whether or not they have symptoms. So 6 months is the big testing where we do everything. And every 3 months, you want to make sure that you're checking the HIV test, you're doing risk assessment and counseling, but you may or may not need to do STI testing. So who is eligible for PrEP? Really, you have to be HIV negative. So that's the primary eligibility. And you should not be initiating PrEP in someone that has symptoms or signs of acute retroviral syndrome. That's, unfortunately very nebulous symptoms like fever, fatigue, myalgias, rash, headache. Pharyngitis can be a presenting symptom, cervical adenopathy, arthralgias, night sweats, and diarrhea. So it's nebulous. But if someone is presenting with any sort of generic infection-like symptoms, maybe hold off a bit. Retest them for HIV and make sure that they are not experiencing acute retroviral syndrome. You want to also ensure that they're not in any contraindicated medications. And again, document their hepatitis status. So who should not be prescribed PrEP? We do not want to give it to people with HIV. Really do need to confirm that. But that's mostly the major contraindication to PrEP. And again, with the renal insufficiency problems, if someone's kidney dysfunction is less than 30 and they are not on dialysis, it's unclear whether it's safe to continue them on PrEP. And I think a lot of people, including patients, are really concerned about well, how do I pay for this? This seems like something, is it like Viagra where they're going to make me pay out of pocket? I think thankfully today, most insurance plans and Medicaid programs will cover PrEP, although you may need to be doing some prior authorization. But if for whatever reason they cannot receive PrEP because their insurance won't cover it, there are several patient assistance programs that you can also access. The company that makes Truvada and Descovy, which is the tenofovir alafenamide emtricitabine combination, also offers some copay assistance. And for some folks that they may choose to go that route, and some states have their own PrEP assistance programs as well. So what do you do if your patient accidentally acquires HIV? So you want to perform confirmatory HIV testing. You want to make sure that they have HIV. You want to immediately treat, or if you're not comfortable with treating because you don't have that knowledge base, please refer them for treatment. And currently the guidelines recommend continuing them on whatever PrEP regimen they are on and adding either dolutegravir or a protease inhibitor, so like cobicistat and dolutegravir. Counsel on methods to prevent onward HIV transmission. So, say, hey, you've got HIV, please use condoms now, until we can get you undetectable. At the same time, an HIV diagnosis can be one of the most traumatic events of a person's life. So, spend a lot of time talking to them about, this is a chronic illness now, it's like diabetes. In fact, you are expected to have a longer lifespan than someone with diabetes. Talk to them about undetectable equals untransmittable, we'll get your viral loads undetectable. You won't be able to transmit it to anyone, it's safer to have sex with you than someone who doesn't know their status. And all those things can really help someone with that first HIV diagnosis and report the case to the local health department. Okay, so post-test question. Which of the following is a contraindication to PrEP? HIV infection, mild kidney disease, continued injection drug use, all of the above, or do not know? HIV infection is the only true contraindication to PrEP. I mean, maybe someone that has an allergy to it, but there in any other situation, it really is more nebulous.
Now that I'm an older man living with HIV and I've seen the whole arc of the treatment developments, it really is a different situation.
My treatment has improved immensely. I have been most of my life on treatments with 6 to 7 pills every day, 3 in the morning, 4 in the evening. That usually was the case. Over 1 year ago, I was switched to a regimen of 1 pill a day. So to me, that was just an amazing switch because I only had to worry about the 1 pill. Aside from the fact that I do take other medications for other conditions, but it just made it so much easier in all aspects of my life.
My medication regimen has changed quite a lot over the years, and I used to take a handful of pills that added up to around 45 per day, breaking it down into like 10 pill increments for each dosing. But fortunately, I've been around long enough that now my dosing is just 2 pills a day. 1 pill I take twice a day, 1 pill once a day. So that makes it pretty easy.
HIV becomes more of a challenge as we age. I am now taking 1 pill once a day to treat my HIV. All of my other comorbidities and complications have brought me back to now where I am taking 11 pills throughout the course of my day.
Going on into the 90s, I was able to get into a few protocols testing new medications. But from those protocols, side effects did happen from some of the medication. So I do feel neuropathy from some of the old meds that I'd used.
What I've learned these days is that when I go into my doctor or a new provider, I have a list of all my conditions. Because they have to be aware of everything I've been through or what I take in order to manage my health.
I really have formed these great partnerships now with the clinicians, that takes care of me today because guess what? It's about me. It's about my life. It's about my livelihood. It's about the outcomes. And as I learn these things, I got to say, I share it with members in my community.
I'm the one who's responsible for my health, so I need to make sure that whoever is going to say, take this or don't take that, that they know the whole picture.
Thank you for that great video. It's wonderful to hear these stories and hear about the kind of complex relationship many people can have with their disease and with the medications they've had to take in the past and currently take as they get older. So before we dive into this section, we've got a pre-test question asking, at what age do people living with HIV generally present with age-related comorbidities, such as cardiovascular disease or kidney disease? And the choices are 45, 50, 55, 60, or don't know. So we'll give people a chance to answer that question. And we'll kind of move into some of the explanation around that. So what we've learned is that people with HIV experience aging comorbidities at an earlier age. And this is a great graphic representation of how many people have none, 1, 2, 3, or 4 or more comorbidities. And as you can see, on the left is people with HIV, and the older they get, the more comorbidities they have, not surprisingly, whereas in HIV negative controls, it's markedly less. No big surprises there. So what are these comorbidities? So they include geriatric syndrome. So that's why we talk about HIV and aging, because it happens earlier and they have these geriatric syndromes, starting with frailty and moving up to pre-frailty at over half, difficulty in activities of daily living are nearly half, cognitive impairment is nearly half, depression is close to that, and on down the line. So we need to be aware that people are having these problems, often in combination, and we need to address those. So there's been a kind of an ongoing debate over the years over whether this is accelerated aging or accentuated aging or both. And I think the consensus now is that it is both. And quite frankly, it doesn't matter. If it's happening, it's happening. And that's what's most important to the patient and to you as a provider caring for them. So they've learned that, looking at all the various cohort studies, the age-related comorbidities, such as cardiovascular disease or kidney disease, present about 10 years earlier in people with HIV compared to their HIV-negative counterparts. So this happens at about age 50. So that's when we talk about, aging with HIV or older people with HIV, we talk about 50. In the general population, we're talking about 60 or 65. For people with HIV, that magic number that people agree upon is 50. Why is this? Well, it's attributed to the ongoing inflammation from the HIV itself, the fact that people have taken a lot of the older, very toxic drug regimens back in the day. The D drugs are a great example that cause neuropathy and lipodystrophy. And then we need to be aware that people living with HIV often have increased risk factors, such as higher rates of tobacco use than in the HIV-negative population. So there's a number of things combining to make this happen. So this is a very busy slide that's not meant to be readable, if you can. I know my aging guys had trouble with it. But this is just an example of the recommended routine healthcare maintenance for older people with HIV and all the things that as a provider you should look at. And I know Miley's going to be talking about that more in the next session, so I won't belabor that point. But there are a lot of commonalities now between HIV medicine and geriatrics as people living with HIV are getting older. As we know, more than half the people living with HIV now are over 50 and beginning to experience these issues. So again, I don't need to belabor the list, but we do want to think about the severity of comorbidities in geriatrics compared to HIV. Obviously, medications are an issue. Anybody seeing their doctor needs to have a problem list. That list gets longer if you have HIV and are aging. Mental health is an issue. We need to think about nutrition. Social circumstances, especially for people with HIV who are at higher risk of depression, anxiety, and social isolation, especially now during COVID when it's just gone through the roof for many people. The environment they live in and how does that affect their safety and their health. And then multidisciplinary, which is going to be kind of the key thing here as we move forward as these things combine. So what are these geriatric concepts? So we talk about the M's. And there's the 4 M's, what matters most, the mind, mobility, and medications. The 5 M's, which includes the multi-complexity of comorbidities and multimorbidity. And the 6 M's of what's modifiable among those, something you can actually change working together with your patient. So we can explore these a little more. So what matters most is understanding the personal health goals and care preferences of the patient in front of you. So it's a partnership, or ideally should be, where you align the care according to the preferences of what those healthcare goals are. And we need to bear in mind that this is not just end-of-life care. People have a long life ahead of them, and so we need to prioritize managing all those multiple comorbidities that they have and talk about the risk-benefit discussions of what you do to manage it. Is adding an extra pill going to be causing more problems than it helps? And just, it's a common concept in geriatric medicine that we need to be applying in HIV as well. And then the mind, cognitive functioning. This is a big concern among people with HIV. I know in the research, some of the research we've done here in Palm Springs, where we asked people living with HIV to prioritize what's of greatest concern, one of the top three was concern about losing cognitive function. So it's really important to identify and manage any cognitive decline or early dementia that you might see, and inquire about safety as a result of their cognitive impairment, putting themselves at risk. And just like you would in the older patient, we do what we can to optimize cognition. So if they're having any mood disorders, such as especially depression is really common, it's important to diagnose that and treat it. We need to explore the mediators and moderators. So what are the social prescriptions that we can give to patients, getting them active and involved in their communities, to end this social isolation that causes depression, and substance use. And I don't think we can emphasize this enough. Just like sex, substance use doesn't magically stop at 50 or 60 or whenever. The people have been using drugs, they're going to continue to use them. Often they start to abuse them as they're trying to self-medicate the social conditions they're experiencing. And then, of course, maintain mental activity, keeping yourself sharp, engaging activities where you use your brain on a daily basis to keep everything working. Use it or lose it, right? And then mobility, of course, is hugely important. Another use it or lose it thing where physical functioning is dependent on continuing to be mobile. So maintaining somebody's ability to walk is crucial. So you may need to prescribe exercise to people. Easier said than done. It's these kind of so-called modifiable sociobehavioral activities that are the most obvious, but often the hardest to get people to do. And also we need to think about safety in the home, preventing falls. So having an evaluation of the home to see if there are risks that can be loose rugs and things like that can be changed to make things safer. Balance training, so prescribing exercises, working with a physical therapist. And this comes up over and over again, polypharmacy. People are already on a lot of drugs as a result of their HIV. As they get older, they have to take more medications for that, and managing that polypharmacy is key. So that, of course, polypharmacy is medications, and we need to bear in mind that as people get older, that changes how their bodies metabolize drugs and how they eliminate them. So we're thinking about the pharmacokinetics and pharmacodynamics, and thinking about the increased harm to benefit ratio in older people, just as you do in anyone who presents for geriatric medicine. And we need to think about only giving them the medications they actually need. People see lots of specialists, they tend to pile on the medications. Some patients are happier if they go in for some kind of complaint that they walk out with a prescription, but that's not always the best thing. So we need to avoid medications that might alter their mind or their mobility, and not overprescribe. And the corollary to that is to deprescribe. If somebody comes to you and they have lots and lots of medications, you need to really take a close look at that and stop the prescription cascades where you end up prescribing more medications to deal with the side effects of the medications they're already on. Many people with HIV are familiar with this from early in the epidemic, when they had toxic medications that they had to manage. And those same problems present as they get older, even with better HIV meds. And then multi-complexity. So obviously we're having to manage a variety of health conditions as people get older, and that's above and beyond their HIV. So that's the highest priority, is screening and treating those conditions. And it's, harkens back to the matters most concept that we were talking about earlier. And we need to think about the context of their social and living conditions. Are they safe? Are they in their home, physically safe? Are they safe from partner violence or elder abuse? What are their neighborhoods like? Can they get outside and safely walk around the block in their neighborhood? Is the park a safe place for them to be? And then social isolation. Again, this is huge. I can't overemphasize this enough. We often talk about AIDS survivor syndrome, where people experience PTSD from having lived through the pandemic and watching all their friends die, and the horrible political situation. And of course, now with COVID, for many, it's deja vu all over again. And then we need to think about stigma. This cuts across the board with all aspects of HIV, and it doesn't magically go away when you get older. Fortunately, many older people do have developed coping mechanisms, but as you get older, people start to face aging stigma. Aging stigma is, of course, a big problem in the US overall, but especially in the LGBT community, people talk about feeling invisible as they get older. and that stigma can exacerbate social isolation or drug use as people self-medicate to address that. And access to transportation. Can they get around? Can they get to their doctor's appointments? Are they driving? Are they able to drive safely? And if not, is there safe public transportation that's available to them? And do they need other options to get where they need to be? And so, of course, we want to look at what's modifiable. What can we change? So 50 is still relatively young, we like to tell ourselves. So an ounce of prevention is always worth a pound of cure. So we focus on prevention. And we should be prioritizing things that impact multiple systems. So, of course, number one is physical activity. Keeping active, mobile helps pretty much every aspect of health in anyone, aging or not, HIV or not, but especially as you get older, it becomes more and more important. We're back to the use it or lose it idea. And nutrition, of course, is hugely important. You are what you eat. And as you get older, your metabolism slows down. People need to think about preventing weight gain because that could cause a cascade of problems. And also eating healthily and being able to do so on what are often limited incomes for many people. So making sure they have access to food support programs, food pantries, that sort of thing. And substance use is always something you need to think about in anyone, but especially as people get older, how people react to drugs, be they prescribed or illicit, changes as they get older. They may be more susceptible. Cannabis has become much more popular as it becomes legalized. And of course, the HIV population have been using medical marijuana for a long time. It was many places it was legalized specifically for use by people with HIV. But as you get older, does that put you at greater risk for falls and cognition problems? So that needs to be evaluated. And connection, again, that social interaction with people, that it's so important to keep them from becoming socially isolated and depressed. And stress is a huge factor. And I think we're seeing a lot of that now during the COVID pandemic as people are encountering things they haven't encountered for 40 years for many of us who were living through the early AIDS pandemic, and that's come back. So we need to think about that, PTSD and those issues, because that can impact how people age and their quality of life as they do so. So basically, the whole idea of looking at what we could change is getting the most bang for your buck. Pills may not be the answer, so we need to look at those modifiable factors. So as a provider, how do you implement this into your practice? Well, it's important to take advantage of that Medicare annual wellness exam that many people may have access to. It's completely paid for. And also, it's important to remember that many people with HIV, even though they're not 65, are already on Medicare. Many have been for decades. So this is available to them. So even if they're not 65, you can start at 50 and above doing the annual wellness exam. And when people come back for their 3-month visit, there needs to be a different focus for each one. There's not enough time, as we all know, in provider appointments to address all the issues. So you need to make sure that you focus on all the issues sequentially as you see these patients, and make more appointments if needed if you can't cover everything in one visit. And then we'll talk about this more later, but we need to think about introducing aspects of a comprehensive geriatric assessment, or the 6 M's that we talked about earlier, and incorporating that into people's healthcare plan. And we also need to encourage and support other staff to pursue training. So social worker training and geriatrics, that sort of thing, so that you have kind of one-stop shopping for people, so you can address the needs that come up in their appointments, and people can refer them to other care and help them address their issues to keep them as healthy as possible. So we're going to go back to that question we asked earlier. At what age do people living with HIV generally present with age-related comorbidities like cardiovascular disease or kidney disease? And the choices were 45, 50, 55, or 60. Don't know. $50 is the magic number.
Everyone, don't forget to please submit your questions for the Q&A segment, which will be following this section by Dr. Karras.
Thank you so much. So before discussing simplifying regimens, and I'll try to make this fast. I know we're running a little long, and I apologize for that. It's just so fun for us to talk about this issue, these topics. So treatment is recommended for which group of people with diagnosed HIV? Those who are not co-infected with hepatitis C, those with CD4 counts greater than 350 cells per mil, those who have symptoms of HIV/AIDS, those who have confirmed HIV regardless of CD4 count or do not know. I'll give you a couple seconds. So first, we're going to talk about treating the older patient before we talk about simplifying. So just like with younger persons, early and potent antiretroviral therapy, or ART, should be started immediately for older adults that are diagnosed with HIV. And our current recommendations for regimens are quite simple. They're not like they used to be in the olden days. Most of them are one pill once a day, like bictegravir, tenofovir, alafenamide FTC, dolutegravir, abacavir, 3TC, or there are 2 pills daily or twice a day. So dolutegravir plus FTC or 3TC is 2 pills once a day. And raltegravir plus FTC or 3TC and tenofovir or TDF is also 2 pills. Depending on what formulation of raltegravir you use, you may have to dose that twice a day. But there is also another regimen, and this is most recently added to the guidelines, of 2 drugs. So if you look here, most of our drugs, and historically all of our drugs have always, our drug regimens have always contained 3 separate drugs. But there is a growing body of data for using less drugs. And the current regimen of dolutegravir and 3TC is approved for initiation of therapy, but there are some caveats there. So it's 2 drugs, not 3, and it is not recommended to be used in people with a really high viral load. So they have to have a viral load less than 500,000 copies in order to be eligible for this medication. Some people would be wary about using this medication in people that have low T cells, although that's not an absolute contraindication to it. But the bigger issue is you can't start people right away on this med. You have to first confirm, like that they don't have any transmitted HIV resistance. The biggest concern is this 3TC. It's not common for 3TC to have transmitted resistance, but if it's there, then essentially you would be starting the patient on monotherapy, which is not appropriate. And we also have to ensure that the patient does not have chronic active hepatitis B, because 3TC is inappropriate to treat chronic hepatitis B as well. So that kind of, it's not the greatest medicine because you have to wait and you have to collect all this information. Sometimes it can take weeks, before you get your genotype resistance test. And you really want to engage a newly diagnosed person right away and get them started right away. Because, if you decrease the viral load, you put them on meds, that decreases their chance immediately or their risk immediately of transmitting that HIV to anyone onward. So in general, data suggests that older adults tend to be more adherent to ART than younger adults, but we should really still consider simplifying our patients' HIV regimens, just like, they're now simplified for newly diagnosed persons because of factors that change with age. And Jeff talked about some of these before, so I'll just briefly kind of touch on them and hopefully we can get through this a little bit sooner. So, we've all cared for patients that can't quite tell you which of their 20 medications they have is for what condition they have. Certainly this gets more and more difficult when you have complex dosing. If you have to dose the medication 3 or 4 times a day, it gets really difficult to keep track of those medicines, and they're taking a ton of other medicines. High pill burden similarly is an issue, polypharmacy basically. Other issues such as difficulties with cost. So if someone's on a fixed income and they have increasing number of medications, maybe they could afford, that $10 copay. But a $50 copay now every month makes it more and more difficult to do that. And they may also struggle with some other issues around availability, like transportation. Perhaps they're limited in their physical function and they struggle to even get to the pharmacy to pick up their medicines. And other things such as other comorbidities like mental health that we've been talking about, neurocognitive impairment, could also impact their ability to understand which medications to take and when. So, it's good to simplify our patients' ART regimens. And subtle neurocognitive impairment can actually be quite difficult to detect, particularly as it relates to HIV-associated neurocognitive disease. But, we can start and we can try, and HRSA has actually recommended that we start incorporating neurocognitive testing for our older adults. So this, I think, is eventually going to become the standard of care. There's several easy tools to use in clinic that can help. Currently, I'm using the St. Louis University Mental Status or the SLUMS tool, mostly because it's free. I used to use Mocha, and I actually really liked that tool, but they started charging, so it's not practical to use anymore. So both Mocha and the mini mental status exam or state exam, which you may have heard of before, are unfortunately now you have to pay for them. So SLUMS is a nice alternative and still free. If you do detect any evidence of neurocognitive dysfunction, it's good also to be proactive and refer them to a neurologist. Or if you're fortunate to live in, like, say, Southern California, we have an amazing HIV neurocognitive research center that we love to see people at, and we're always having clinical trials. So other considerations when we're treating the older patient or person who's living with HIV, we talked about neurocognitive impairment. Depression is one of the concerns that can potentially worsen neurocognitive impairment. And there are some antiretroviral regimens that have been associated with an increased risk of depression. So we might want to consider not using things like efavirenz anymore in the older adult because of the increased risk of neuropsychiatric symptoms. Some people, so certainly this is the worst of the efavirenz, although some experts do view neuropsychiatric symptoms as a class effect, and subsequently will also not provide rilpivirine to older adults. Although certainly we do know from clinical trials that the incidence of neuropsychiatric symptoms is much less with that medication. But with polypharmacy, things you need to consider is drug interactions. The protease inhibitors of all of our HIV meds have the most drug interactions that can then lead to some toxicities. And because of that, we do really need to carefully look at our folks that are taking protease inhibitors. As our patients get older, they may accumulate other comorbidities or other injuries to their organs, i.e. their kidneys, that may make it less safe for them to take some of our medicines like tenofovir disoproxil. Atazanavir is also associated with nephrotoxicity, just like the old Crixivan, it can cause crystallization and injure the kidneys that way as well. And, one of the things I think that we don't talk about enough is decreased bone mineral density or osteoporosis. We do know that when people with HIV start their HIV medications, really regardless of what regimen you use, there is some decrease in the bone density. We believe that the mechanism is inflammatory in some way, but that decrease in bone density is the worst when someone is starting tenofovir disoproxil. So if you're already worried that someone has already had some stress fractures, or like they have pretty severe degenerative joint disease, then maybe you need to switch them off their tenofovir disoproxil as well. Patients are at risk for high cardiovascular disease. There is a couple of really large studies that associate abacavir with increased risk of cardiovascular disease. Some of the experts in HIV and cardiovascular disease say the easiest thing to prevent or decrease cardiovascular disease is to not use abacavir. So I think that is now becoming something that providers are keen into. And also medications such as lopinavir, ritonavir, we know increases cholesterol that may further increase that cardiovascular risk. And then the metabolic syndrome, which we are also seeing in our clinics. Protease inhibitors are the most egregious at contributing to that. But don't forget that cobicistat in elvitegravir that's paired with elvitegravir can also cause that because it is essentially a protease inhibitor, just not really effective against HIV. We added this on at the last minute because it's become quite a bit of a hot topic. What is going on with COVID and HIV? So I'll talk about kind of two parts of it. There are certainly care challenges that we've seen arise from COVID. It restricts access to care. Many services that were available before may be limited, particularly amongst our partnering community-based organizations. A lot of them have closed to in-person services completely. So we are starting to also see social isolation worsening and subsequently contributing to worsening mental health and increased substance use to cope with being lonely. I can't even tell you how many times I've had a telemedicine visit with someone, and as soon as I see their face, they start crying because they miss the connection. And increased competing interests. People may not be working enough or may, not have the income that they had before. They're worried about losing their housing. They're worried about being able to pay their rent. They're worried about food. And we know also from years and years of adherence data that the more of these competing interests that people with HIV have, the harder it is for them to take their HIV medications. So COVID has certainly made it difficult for a lot of people for those reasons. But I think the question that still remains pretty unknown is whether or not people with HIV are at higher risk of hospitalization or death from COVID. There's two ways to look at this. So, you've already been told that people with HIV have an earlier and a higher prevalence of comorbidities than people without HIV. That alone increases risk. In the US, the studies that have been done here, most do not show a statistical difference in hospitalization or death. However, studies done in other parts of the world, like Africa, for example, do show differences between hospitalization and death in people with HIV compared to those who don't have it. So I think that question is not a hard yes or no. It really depends, on what population you're looking at, how different are the health inequities, and what's the immunocompromised states of the persons in the population that you're looking at. It still also remains unclear if specific antiretroviral therapy regimens can protect against COVID. And after we put this PowerPoint together, the CDC published some guidelines specifically, and they specifically say that people with HIV we should not be switching their HIV medications until we have more data, that any specific HIV medicine can actually decrease COVID. We don't have that data yet, so we shouldn't be switching things willy-nilly just because we're afraid. They also recommend that people with HIV should receive, the SARS-CoV-2 vaccines, that it is safe and efficacious for them, and we should be recommending it for them as well. And interestingly, I was happy about this, but a little bit surprised. The CDC does recommend that HIV should be a category of risk to be placed in COVID, and that people with HIV should have priority access to vaccines, which is wonderful. I hope that actually bears out, but I'm not really sure how each state is going to take that recommendation. So in general, what we want to do for older adults, we want to treat early. If they're on complicated treatment or if they're on medicines that might cause them more problems, like I discussed earlier, simplify and switch them. Oftentimes it's helpful to partner with our clinical pharmacists because it does get more and more difficult to tease out these drug interactions and more medications that patients are on, especially if they're seeing a whole bunch of different doctors. And, they're getting prescribed a whole bunch of medicines from people not you. Continue to encourage adherence. It's still an issue. I have still a lot of patients that just decide that they want to take a break because they wanted to see how their body felt off meds, even though they've been suppressed and adherent for over 10 years. So it's good to check in periodically. Address mental health issues. This is going to be a bigger and bigger barrier to the health of older adults with HIV. If you identify an access barrier, mitigate that. Talk about sex and substance use. Hopefully we've encouraged you to do that and empowered you to do that in this talk today, because again, they're continuing to have sex and they're continuing to use substances. I personally have seen recrudescence of substance use in my folks that, are lonely to cope with that, and in my folks that have chronic pain. Especially since, we are now limited in how much opioids we are able to give people. A lot of my folks have, resorted to using cocaine again or starting to drink again because they just feel like the chronic pain is so overwhelming. But, it's also important to listen. It's a lot of our folks want to tell us what's going on with them, whether it's loneliness or whether they're struggling with their substance use. And so many times I also fall into this trap. We get just so caught up with the checklist of the things, I got to do the lipid panel, I got to do the T cells. But sometimes that again, this goes back to the matters most. It's not what's really important to the person. It's not what's going on in their life right now. So it helps to often just stop and just listen and see what they have to say and really be open to hear what's going on with their lives. Okay. So here's the last question. Treatment is recommended for which group of people with diagnosed HIV? Those who are not co-infected with hepatitis C, those with a CD4 count of greater than 350 cells per mil, those who have symptoms of HIV/AIDS, those who have confirmed HIV regardless of CD4 count or do not know. So, the first time around, most of you got it. So those who have confirmed HIV regardless of CD4 count, and everybody got it. Yay! You guys did fantastic with this session.
Yeah, thank you so much, Dr. Karras and Jeff, for a great presentation. We've got some questions, and we'll address as many as time allows. I know we're a little over, so thank you for sticking with us. We know it's a very important topic. Dr. Karras, the first question, would you suggest baseline bone density scanning in older people starting TDF prep? And then would you repeat the scan after being on TDF prep for some time?
So it's not currently recommended, but I will say that the guidelines were not developed for people who are 50 and older. And if you don't have HIV, you may not actually be experiencing, like early bone demineralization. So there may not be an increased risk for that. I would do it only if, the person in front of me has had like a fragility fracture or any other symptom or any other condition. So if they're hypogonadal, then yeah, maybe it makes sense to do that before prep, but it's not in the guidelines. If indeed you do identify that someone has decreased bone mineral density, I would treat it and then have a risk-benefit discussion about prep. Whether or not I would repeat it. So the pathogenesis of bone demineralization with tenofovir disoproxil is similar to the pathogenesis of kidney dysfunction. Usually you catch that first. So you would normally catch some evidence of Fanconi syndrome in the urine and in the creatinine before you have the significant loss of bone. So hopefully you stop the tenofovir before it gets to the point where bone demineralization is severe.
Okay, thank you. And we've got another question. How do I talk with a patient who does not want to alter their treatment, but they should?
That's a hard one. I just continue to be persistent. And I usually talk about the negative things. And there are some people, that have been on, say, efavirenz and FTC tenofovir disoproxil and have been doing great on it. It saved their life and they never want to treat or change. But I find that a lot of the hesitancy has to do usually with other things. So usually people are afraid of a new side effect. And, you can talk to them about how the new medications actually are lower side effects. If you know of a side effect associated with the medication that they're on, like efavirenz, for example, you can say, hey, this medication is associated with neuropsychiatric effects. And, you were telling me that you're a little bit more sleepy, or you're complaining of fatigue, or you're complaining about being concerned about your memory. Maybe we need to stop the efavirenz and, try a different, safer, medicine that doesn't have as many side effects and see if that actually gets better. So I think really kind of listen and see, what are the things that they're concerned about? And if you are aware of a side effect of the medication they're on that needs to be updated, you can kind of tease some of that in to help convince them that, really this is better for you.
And one thing to add to that is that a lot of people had it drilled into their brains early on that you needed to preserve your treatment options when there weren't many. And that's changed, of course, but people still have that mindset. Because I have a lot of friends who are, it's like, I don't want to burn through my options. And we need to remind them that we have a lot of options now. There are new drug classes, and people don't need to worry about that like they used to.
That's a great point, Jeff. I often tell people, who are really skeptical, I'm like, if you don't like the new medicine, we can go back. It doesn't mean you can't go back to your old medication if you have some sort of unusual side effect to the new one. And that often convinces people to do it.
Right. What is the HIV incidence rate while using PrEP? And are those cases likely because of adherence issues?
Very, very low. Maybe Jeff has the exact number. I can't remember it off the top of my head. And yes, So we know from the very early PrEP days that most of the cases of HIV were related to suboptimal adherence. It is a very rare occurrence that someone develops or acquires HIV while they are adherent to PrEP. And in those cases, it's usually a variant of HIV that is resistant to FTC and tenofovir. Unfortunately, there are still people in the community circulating that have high level resistance and for whatever reason are still not taking their meds correctly. But that is a very, very, very rare occurrence.
Okay, question for Jeff. Is PTSD for long-term survivors widespread now with COVID?
Well, it was widespread before. So I think that's what you need to remember. And interestingly, we've done some preliminary research on this. And what we've learned is that, and I hear this anecdotally from providers as well, is that people who lived through the HIV pandemic had better coping skills than the general population because they'd been to this pandemic rodeo before and they knew what to do, knew where to get trusted, reliable sources of information. They're used to following medical guidance and, keeping themselves safe and so forth. They wouldn't be here if they couldn't do that. So ironically, some are doing better. But I think, what we need to look at is what's going to be the cumulative effect. And I think it's too soon to say. But anecdotally, again, what I'm saying is that it's the isolation is what's really driving people's unhappiness and mental problems.
Dr. Karras, what are the most important features of a drug regimen? Does once daily trump fewer side effects?
The most important features of a drug regimen is what matters most to the patient. Once daily does not necessarily trump fewer side effects, and everybody is different. I take care of someone who has very brittle depression. And there are several antiretroviral therapies that we've tried that have worsened his depression. So he's on an older regimen. He's on protease inhibitor because it's the only class that he has not associated a worsening of depression in, and subsequently is the only regimen that he will take. So really, it is a discussion between you and the person you're taking care of, figuring out what is important to them, what their priorities are. And when they know that you are tailoring it to them, they will be more likely to be adherent to the medicine.
Well, thank you both. And thank you everyone for watching. If you'd like to claim credit, a reminder, please click the claim credit button and that will appear when the webcast ends. It should also appear on your console now as well. And also please be on the lookout for a 30-day survey. You'll receive that via email. As always, your responses do help us develop further education, so we do appreciate you taking the time to do that. We thank you for joining us. Dr. Karras and Jeff, thank you so much.